Sure.
Praveen sir, can we please start the recording? Good afternoon, everyone. iTech India welcomes all the participants for today's special National Distance Learning Seminar session. Today's session topic is Determinants of First-Line ART Regimen in Children Living with HIV. We'll be discussing the case scenarios. And the speaker is Dr. Rohini Gupta, ma'am. Dr. Rohini Gupta, ma'am, has completed her MBBS and MD in Pediatrics at Armed Forces Medical College, that is AFMC, Pune. She has more than 30 years of broad-based experience in healthcare and 12 years of experience in HIV care. She has actively participated in the NACO Pediatric Training Technical Resource Group, that is TRG meetings. Currently, she is engaged by SAATHII as technical expert for developing the national level training curriculum for CST staff and elimination of vertical transmission of HIV and syphilis guidelines for NACO. We welcome you, ma'am, for today's session. There are two things to be noted by the participants. One is please keep the pediatric dosage chart ready for reference during the session. And second, all the question answers will be taken up at the end of the session. So please keep posting in the chat box. We will quickly run the pre-test. Praveen sir, can we have the pre-test, please? Right. The pre-poll question is now visible on your screen. All the participants are requested to please attempt all the 4 questions. We have 5 minutes for the pre-test, so please go through the question carefully and answer it. Requesting all the participants to please answer the pre-poll question. Requesting all the participants to please take the pre-poll. We'll end the e-poll now. Rohini ma'am, we once again welcome you for today's session and request you to start the session.
Thank you, Shweta. Am I audible?
Yes, ma'am.
Okay. Good afternoon, everyone. Welcome to this session. And please put your questions in the chat box. And whenever we come to a case scenario, I would like you to raise your hands so that we can unmute you and you can answer the question. So let's start with ART in children living with HIV. What are its goals? Is it different from what we have goals in adults? So there are certain goals which are similar to what we have when we are talking about ART in adults, that is prolong the survival and improve quality of life, reduce morbidity, suppress HIV replication, that is reduce the viral load. But there are two things, and the last is preserve and enhance or reconstitute the immune system so that the number of opportunistic infections are reduced. But there's an additional goal which we have is to promote optimal growth and development. Because remember, if the child is not virally suppressed or the child is though taking ART but is not growing well, we need to monitor this growth and development. How is the child faring in the growth and development process? So ART plays a ART and viral suppression plays a very important role in the growth and development of children who are living with HIV. So what are the special considerations which we have in children who are on ART? So the doses, remember that the doses of all the ARV drugs are based on the child's weight and age and need to be adjusted periodically, because as the child's weight increases, the weight band shifts. So that's why it's very important to have a pediatric dosage chart. So the first step is to find out what is the ART to be given, which is based on weight and age. Once the ART regimen is decided and started, thereafter we need to keep checking the weight of the child and checking whether the dosage given to the child is correct, because as the child grows, takes ART, the child is going to grow and gain weight, and we need to check what is the dosage. Sorry. Children differ in adults because of the body composition, renal excretion, liver metabolism, gastrointestinal functions, enzyme maturity. So ART works in a different way because their systems are not mature, especially in small children who are less than 5 years of age. Their various systems are maturing. So we need to monitor these so very carefully in children.
Ma'am, we'll take a 2-minute break.
No, it's okay. It's okay. It's okay. Pharmacokinetic issues are that the drugs are absorbed in a different way due to transition from the newborn period towards childhood to adulthood. And therefore, we need to evaluate whether the drug dosage is correct or not. Remember that the child's body surface area is more, and the weight is also going to be changing as the child grows. So the dosage also has to be increased. Otherwise, the ART will not be effective. So what are the steps in preparing a child for lifelong ART? Is it different from what we have in adults? Yes, it's slightly different. The reason is that we are now going to be breaking the news to the caregiver that that child has got HIV. That's one of the most important things. The parents are not going to be accepting that their child has HIV. So you have to break the news very softly, explain to them, build a rapport with the caregiver or the parents. Then in children, if the parents are the caregivers and they are also HIV infected, then we need to have a second backup caregiver. Clinical history and physical examination, very important. You need to do head to toe, because the child is not going to be telling you what complaints the child is going to have, but would have hidden infections, especially skin infections and oral infections. So a clinical examination from head to toe, you need to see the genitals also. You need to see the limbs, the fingers and the feet properly to look out for scabies, other skin infections. Baseline lab evaluation is the same which we have in adults. And preparedness counseling comes to the same. The only difference is that here the child has to be prepared to be taking medicines lifelong. And you have to explain to the child. So in an adult, you're just explaining to the adult patient and the caregiver. But here you have to explain to the caregiver, a second backup caregiver, and the child. And the child will have to explain in simple words why this medicine has to be taken. Psychosocial assessment is especially important uh, in adolescence, where you'll have a lot of non-adherent issues. So a baseline psychosocial assessment and ongoing psychosocial assessments also are very important. After doing the baseline evaluation, you need to have an evaluation and diagnosis of any OIs, treat the OIs, and CPT initiation. So we'll be talking about CPT initiation in detail. Remember that we need to take an informed consent from the parent, caregiver, or guardian of a patient who's less than 18 years of age before ART is initiated. This is a very important thing. Adults may you take the patient's consent, but in children who are less than 18 years, even adolescents, they have to, a parent, caregiver, or guardian has to be identified and who will give consent that yes, they are willing to have the child take the ART medication and follow up at the ART center. Breaking the news to the caregiver, we need to identify a primary caregiver, may need to identify a backup caregiver. We need to establish a rapport, inform the caregiver about the status, find out if there are other children have been tested or not. If they have not been tested, counsel the parents to get them tested, find out if the parents are HIV infected, find out what is their ART status, how are they adherent? Remember, non-adherent parents will is a risk factor for the child to be non-adherent. Also find out whether the parents are on first line or second line ART by looking at their green book. Then sensitize the caregiver about disclosure. So there is something called age-appropriate disclosure of HIV disease and disease information that needs to be given to the child. This disclosure is done by the parents, but can be supported by the counselor and the medical officer, because the parents will find it very difficult to explain. So disclosure is a stepwise disclosure, which probably will be discussed in other places. But remember that this we need to sensitize the caregiver that you need to plan to tell the child gradually as per the age, the disclosure as per age about the HIV status. This will help in adherence of the medicine. Otherwise, the child is going to keep asking, why am I taking medicines and the others are not taking medicines? So what are the key steps? You do an initial head-to-toe examination. We initiate CPT in those where it is indicated. All children less than 5 years need to be started on cotrimoxazole preventive therapy. We'll be speaking about this in the next slides. ART preparedness counseling, already told. The most important thing is that we must look for opportunistic infections, stabilize the patient. Don't start ART in a child who is having infections or is having vomiting, diarrhea, because the child is not going to be able to take the ART medicine. So ART is to be started in a stable child. Clinical assessment, as I told you, head to toe physical examination, very important. You need to do growth assessment, weight and length and height in the WHO charts, which are there in the guidelines, national guidelines, in the annexures. All the charts are given. It's very important. At the baseline, before starting ART, you need to note down what was the weight and the height or length of the child as per the age. And thereafter, you need to plot it. Similarly, development assessment is to be done by the Trivandrum development assessment chart. This too has been explained in the national guidelines, and you need to follow up the development and the growth assessment, whether the child is achieving all the milestones or not. The most important thing is that we need to find out if there is nutritional status. What is the nutritional status of the child? So there are some things which we must know, that is lethargy, oral thrush as seen, this whitish past on the tongues, wasting, signs of malnutrition, anemia, edema is pedal edema, which is present, and pitting edema, which is present because of a consequence of protein deficiency, signs of vitamin deficiency, which may be seen in the eyes as white hot spot, in the tongue, or a corneal haziness, muscle wasting. If you can see in this, there's evidence of muscle wasting, and features of opportunistic infections. It's very important that when you're starting ART, along with ART, if the patient has signs of nutritional malnutrition or vitamin deficiencies, we need to supplement with the vitamins which we have signs of deficiency. And also nutritional counseling is very important for the viral suppression to happen. So in a child, that is important, in a child who's got malnutrition, vitamin deficiencies, the ART may not be as effective if you do not supplement it with. That is, the child may not gain weight even though the ART is working, even though there's viral suppression. It will not, the ART will not work because the child is not getting adequate nutritional supplementation or nutrition for its age, because the metabolism is increased in children living with HIV, and they need more calories and proteins. Plus, the vitamin deficiencies also need to be supplemented. So the next is seriously ill child. It's very important. Every time you see a child living with HIV, you must look at whether the child has got any signs of a serious illness. So these are called, in other words, danger signs. So there are basically 5 danger signs. You can see this child has got danger signs: lethargy, unconsciousness, convulsions, unable to drink or breastfeed, repeated vomiting, and other clinical features such as high fever, fast breathing, chest in drawing, etc., where you say that the child is. So any one of these signs present will say that a danger sign for a serious illness is present, and this child needs to be referred to an appropriate higher level facility for management, hospitalization, and preferably a pediatrician evaluation. Now, which children require evaluation by a pediatrician? So desirable that all children living with HIV should be assessed comprehensively by a pediatrician who have got experience in HIV care. But where pediatricians are not available, it's important that we refer those children who have malnutrition, are not gaining weight, or have growth failure, or their growth curves are on a downward trend. There is developmental delay, that is, the child has not developed the milestones as per the age, or it has lost certain milestones which they had achieved, or has some systemic disease, has signs of serious illness, and or a sign of presence of some systemic opportunistic infection. So these are the children who absolutely need to be evaluated by a pediatrician. So what are the screenings we need to do in children? The 4S screening, if you see the 4S symptom, it's different from adults. We have current cough and fever, which is the same, but we have poor weight gain. Now remember, poor weight gain includes weight loss and not gaining weight. So weight loss is included in poor weight gain. Either there is weight loss or the child is not gaining weight. Both these fit into the definition of poor weight gain. And the most important is history of contact with TB case. So all children with presumptive TB. So what is a child with presumptive TB is that if the child has one single of these 4S symptoms or more. So even a single symptom present in a child or living with HIV of these 4S symptoms is called a presumptive TB and needs to be evaluated. I agree, you will say that fever could be because of a throat infection. It could be because of some viral infection also. But then these children would be taken as presumptive TB and would need to be evaluated by the medical officer by looking at the throat and this thing, that does the child have any more symptoms or signs of TB. But they are taken as presumptive TB. We do not differentiate the 4S symptoms with URTIs. We have to examine head to toe and rule out whether this child has other signs of TB or it's just a URTI or a throat infection. That is why a head to toe examination by the medical officer is very important. Those children who are not where TB has been, active TB has been ruled out, need to be put on TB preventive therapy. And on INH. OIs should be treated and stabilized. There are only two OIs which you need to start ART without waiting for it to resolve. One is MAC infections, that is Mycobacterium avium complex infections, or if progressive multifocal leukoencephalopathy, that is PML, is present, these two, ART is its treatment. So you do not wait for them to stabilize. If they have either of these opportunistic infections, we need to start ART immediately because ART is their treatment. But otherwise, most OIs, even if it is fever, even if it is pneumonias, diarrheas, we need to treat the infection, stabilize the child, because an unstable child who's having vomiting or loose motion will not absorb the ART drugs which you're going to be taking. So it's going to be useless. So let the child stabilize, the OI gets treated, and after that we start ART, where the ART drugs will be absorbed properly and will be effective. We have a treat-all policy, but then in children, we need to have a baseline CD4. What is the importance of a baseline CD4, even in the context when we are starting ART in everybody? So one is to monitor the treatment response. Remember that children less than 5 years of age, we need to do CD4 counts, and we do not, even if there is viral suppression, we do not stop the CD4 counts. The CD4 monitoring is continued for all children less than 5 years of age. To diagnose iris, to anticipate OI infections, if the CD4 is fallen, think of OI infections. If the CD4 has gone up and the child has infection, think of iris. We need to talk about OI prophylaxis. In children more than 5 years of age, the criteria for CPT is based on the CD4 count and clinical stage and immunization advice. So all children who have CD4% of more than 15% would can be given live vaccines. So the question will come from the parents, can we give all the vaccines? Yes, most of the vaccines can be given. The live vaccines, we need to know whether the child is got a CD4% more than 15% to get measles and MMR. These are live vaccines, and for this we need to have an idea about the CD4%. Remember, these are a few things which we need. We all need to remember that CD4 levels in children are considerably higher than in adults due to lymphocytosis. They become equal to adult values by 5 years of age, and infants and children less than 5 years of age. The important thing is not to look at the CD4 count, which may be more. We need to look in children less than 5 years of age, the CD4%. That will give us a better indicator of what is the immune deficiency. So cotrimoxazole preventive therapy, or what we call as CPT, we need to give cotrimoxazole suspension in all children less than 5 years of age. Why do we give it? It reduces the morbidity and mortality in children living with HIV. In simple words, if you say it in Hindi, we say जानलेवा बीमारियों से बचाता है. HIV को कम नहीं करता है, HIV पे काम नहीं करता है, but जानलेवा बीमारियों से बचाता है. और कौन सी जानलेवा बीमारियां हैं? जानलेवा निमोनियाज और डायरियाज. So CPT is effective in pneumocystic carinae infections, or now what you call as PJP pneumonias, toxoplasmosis. Certain bacterial pneumonias also are protected by CPT, nocardiosis, and diarrheas due to enteric like isosporiasis. What is the dose? 5 milligram per kg per day of trimethoprim given once a day. Don't remember it as 5 milligrams per. What we need to have is on the table, we need to have this dosage chart. It's given in the guidelines, but don't remember it, don't calculate it, keep it ready reference. If you all don't have this chart, please take a pic of it, because the next few slides we are going to be asking a case scenario on the dose of CPT. So cotrimoxazole is given once a day, and less than 5 years of age, we continue giving it till the child reaches 5 years of age. So what are the indications? So if we have one case scenario, I would like someone to please raise their hands if you would like to answer the questions. So baby, an HIV infected 2 years old child has persistent oral cough, has achieved normal milestones, but has failed to gain weight and height. Weight is 6 kgs, height is 72 centimeters, CD4% is 18%, HB is 7, TB has been ruled out. So what is the clinical stage of this child? Just to give you a hint, look at the weight. It's less than -3 Z score. Height is less than -3 Z score. Anybody wants to answer? Any raised hands, Shweta?
Not yet, ma'am. Participants are requested to please raise their hands. For raising their hands, there's an option at the bottom of your screen in the Zoom window. There's a reactions icon there. When you click on that reactions icon, you can find that raise hand.
Or you can put it in the chat box. Yeah.
Yes.
If somebody wants to answer, you can put it in the chat box if you don't want to raise your hands and identify yourself. Let me see some answers in the chat box if you desire. So very simple thing. What is the clinical stage of this child? And is CPT indicated in this child?
Ma'am, the answers are stage 2, stage 3.
3. Okay. What about the second question, CPT? CPT is indicated. Stage 4, CPT is indicated. Any more answers? So I'll just tell you the answers because we've got lots of case scenarios remaining. So clinical stage 4, because it's a severe malnutrition, where though the milestones is normal, but the child is less than -3 Z scores and height is -3 Z scores, and TB has been, OIs have been ruled out. Is CPT indicated? Yes. All children less than 5 years of age, irrespective of clinical stage and CD4, they need to be given CPT. Can somebody just tell me what is the dose? I showed you the dose. Should I wait for an answer about the dose or should I tell you all the dose? CPT, yes. So I'm getting answers as CPT, yes. So what is the dose? The dose is syrup co-trimoxazole, 40 milligram of trimethoprim per 5 ml. That is the syrup bottle which I showed you. Dose is 5 ml once a day. And we continue it. But remember, as the child gains weight, so as the child gains weight, the dose of CPT will also increase. So you must remember not only to increase the dose of the ART drugs, we need to increase the dose of the co-trimoxazole dose also. So yes, I got 2 answers, 5 ml once a day. Very good. Thank you for interacting. I'm very happy. So let's go to the next slide. So let's just revise what are the indications for CPT in CLHIV. So all HIV exposed infants and children from 6 weeks of age or at the first encounter need to be put on CPT, and they should be continued on CPT till HIV infection is excluded at 18 months, or if the mother is breastfeeding, then 3 months after stopping breastfeeding, regardless of ARV. So you need to continue CPT if the patient child is negative after at 18 months, or if the mother is breastfeeding 3 months after. So the last testing in a breastfeeding baby is 3 months after stopping breastfeeds. If that is negative, then you stop the CPT. And if the child is detected positive HIV infected, then all HIV infected up to 5 years of age, regardless of WHO and CD4 count and CD4%, we need to give CPT. At 5 years, we have to see what is the CD4 count and what is the clinical stage. If the child is maintained a CD4 more than 350, 6 months apart, 2 reports, and the clinical stage is 1 or 2, we can stop the CPT. But if the clinical stage is 3 or 4, or, so it is or, remember CD4, it's not and. Either it is WHO's clinical stage 3 or 4, or a CD4 count less than 350. Either of them is present, we need to continue the co-trimoxazole syrup. HIV infected more than 5 years, we look at the criteria which is for adults, that is WHO stage 3 and 4, regardless of CD4 counts or a CD4 less than 350. And we stop the CPT when there is clinical or immunological criteria, that is the child should have been, in this it is and, that means both criteria should be met, that the child is more than 5 years of age, is in WHO 1 and 2 stage, and the CD4 across 2 reports 6 months apart is more than 350. Then we stop the CPT as we do it in adults. And secondary prophylaxis, we need to give secondary prophylaxis of PCP after treating pneumocystic carinae infection. In less than 5 years, we do not stop, we continue. If it is more than 5 years, we continue till the child is WHO clinical stage 1 and 2 and the CD4 is more than 350. So when you're stopping, both criteria should be there. When you're starting, either one of them can be there. Both don't need to be there. If the child is in clinical stage 3 and the CD4s are high, even then, because the clinical stage is 3, that is, the child has got lymph node TB, then the child, but the CD4s are maintained, it is 400. Even then, we would continue CPT because the child is in clinical stage 3. So while starting, both, either of the two criteria, should one of them can be present, you need to start. But for stopping, both should be present. That is WHO clinical stage 1 and 2 and a CD4 more than 350 on 2 occasions, at least 6 months apart. So preparing a child, always remember these 4 questions: what, when, how, and who. Whenever you are seeing a child with a caregiver, it's very important ki kya kha rahe ho? Medicines, what medicines will be given, and you explain to the caregiver what to do when the child vomits, or what to do if you want to go outstation. How are you going to be remembering to give the medicines without disclosure of the disease? The second is when, kitne baje khaogi dawaiya? How are you going to fix it? It has to be fixed according to the routine of the child. So it's very important because children go to school, their timings of their bus also vary. Whereas each child has their own school routine. And as the child grows, so when it's in primary school, the timing is different. When the child goes to secondary school, the timing changes. So these questions are asked not only during the preparation, also when you're doing a follow-up, you need to ask these 4 questions. How is the medicine to be taken? Okay, and to set reminders. So you need to tell them that you need to, mother and father both should keep a reminder in the mobile, so that if one forgets to give the medicine, at least the other one gives. If one of the parents is not there, then the second backup caregiver also keeps a reminder. So that's very important, because most of the children living with HIV are either orphans or their parents are HIV infected, and they may forget to give the child the medicine. So it's very important. Then who will administer the medicine in children who are ill, or if the parents are ill? So that's why your second backup is very important. And the most important thing which in children is required is pre-ART activities. That is, before starting ART, you need to teach the child how to swallow pills and maybe give the first dose. So how do you teach the child to follow pills? You can give small, you can have these small pop-in tablets, but remember, you give pills only after 5 years of age for swallowing. Less than 5 years of age, we dissolve it in, we give dispersible tablets and they are dissolved. So you need to teach the mother also how to dissolve the tablets. So preferably give the first dose in the clinic or in the hospital. This is very important if you want to, because what will happen is that the mothers are not able to give the child medicines. And the first few doses are not taken properly. So what is rapid ART initiation in children? So rapid ART initiation is advised in CLHIV after appropriate preparedness. That is, within 1 week of registration, the child should be started on ART and should be initiated irrespective of CD4 and WHO clinical staging. However, remember that ART is a non-emergency intervention. Treatment preparedness and management of OI is always given priority in children. So if a child is sick, rapid initiation of ART is not the same. We can postpone starting ART, but the important thing is that you need to treat the OI, stabilize the child. When the child is able to take eating properly, then we start ART. And seriously ill and hospitalized children should be stabilized, and ART should be started before they are discharged, so that the ART initiation can happen in the hospital. Once the child is stable, you start ART and the child goes on discharge with the ART medicines. So ART initiation, just a summary. For ART initiation in children, we need 2 things. So remember that tenofovir 300, that is the adult, is advised in children with age more than 10 years and weight more than 30 kgs. And DTG 50 milligrams can be given in children living with HIV with age more than 6 years and weight more than 20 kg. So both these criteria need to be fulfilled if you need to be giving DTG and if you need to be giving TDF. So it's very simple. We need to know two things. One is what is the age of the child and what is the weight of the child. So we have only 3 regimens in children now. It's irrespective of the hemoglobin. So always remember that zidovudine, when we used to give, all the old medical officers who've been here for many years would have initially been talking about what is the HB, what is the HB. Now we do not. We look at the hemoglobin. We need a hemoglobin to treat the anemia, find out the cause for anemia, because that is another nutritional counseling and the nutritional supplementation, which is very important along with ART. But deciding the ART regimen, hemoglobin doesn't play any role. All the role is played by the age and the weight of the child. And remember that zidovudine has now been kept as a second-line drug. So we are talking about ART initiation in children, first-line ART initiation. And in this, the children who are less than 6 years and less than 20 kgs, because we do not have pediatric DTG and adult DTG cannot be given in these children, the regimen is AL plus LPVR-R. So the NRTI is abacavir, lamivudine, plus we give the PI, which is protease inhibitor, that is LPVR. Now, remember, it is less than 6 years and weight less than 20 kgs. If the child is 7 years, but the weight is 15 kgs, both criteria should be met. Only then can you go to the next. So the next weight band and age is those children who are between 6 years to 10 years and weight between 20 to 30 kgs. So here we can give DTG, because as I told you, DTG can be given in children more than 6 years and weight more than 20 kgs. So we give what is called ALD. The regimen is ALD, that is abacavir, lamivudine, FDC, a fixed drug combination, plus we give single dose of adult DTG 50 milligrams. Just to repeat again, DTG 50 milligrams can be given in children more than 6 years and weight more than 20 kgs. Why we have made it as 6 to 10 years and 20 to 30 kgs? Because we cannot give tenofovir. So till the child becomes more than 10 years and till the child becomes more than 30 kgs, we have to continue with abacavir, lamivudine. And once the child becomes more than 10 years and the body weight is more than 30 kgs, doesn't have any renal disease. If it has any renal disease, then again we cannot give tenofovir. So if it has renal disease, even those children who are more than 30 kgs have renal disease need to be kept on abacavir, lamivudine and DTG. Those children who are more than 10 years, more than 30 kgs, no renal disease, can be put on adult TLD. So the adult TLD can be given in children living with HIV who are more than 10 years of age, more than 30 kgs of weight, without any renal disease. So this is a simple thing. The regimen which we have done, I'm just telling you that abacavir, lamivudine comes as a fixed drug combination, and you need to look at the weight to find out what is the dose. It should be given twice a day. And lopinavir, ritonavir comes as syrup, tablets, or pellets. I'll be talking about these formulations a little later. That also need to be given twice a day as per weight band. When we are talking about ALD, remember that abacavir, lamivudine is given as per weight 2 times a day, while DTG is given 50 milligram once a day. In those who are weight 30 and age more than 10 years, we need to find out whether there's renal disease or not. In children who have known renal disease, we'd be giving ALD, abacavir, lamivudine as per weight band, and a DTG 50 milligrams OD. Those who do not have any renal disease will be given TLD, that is a fixed drug combination of adult tenofovir 300, lamivudine 300, DTG 50 milligrams once a day. So now, this is the drug dosage chart. If you do not have a readily available drug dosage chart, please take a pic of this, because now after this we have some case scenarios. So one of the questions which has come in the chat box is that what do you give if lopinavir, ritonavir syrup is not available? So lopinavir, ritonavir has to be available. The SACs are responsible for making it available. Syrup may not be available, pellets may be available, tablets may be available. So You cannot replace in children less than 6 years and less than 20 kgs need to be on lopinavir, ritonavir, whether a syrup, whether a pellet, whether a pediatric tablet, depending on the weight band. And these have to be made available by the SACs. That is the responsibility. There is no other alternative for that. Unless DTG, dolutegravir pediatric tablets, which may be coming in pipeline, they are in pipeline, should be here in our program by about August, September. But till they are not available, we are going to be putting all children less than 6 years and 20 kgs on abacavir, lamivudine, and lopinavir, ritonavir, AL plus LPVR. So now we have another case scenario. Please answer in the chat box, or you can raise your hand. So Miss P is a 2-year-old CLHIV, weight 8 kgs, height 75 centimeters. Both are less than 3 standard 3 Z scores. Cervical lymphadenopathy is there, hepatosplenomegaly is there, CD4 is 18%. So is CPT indicated? And what is the ART regimen? I'll give you half a minute. CPT indicated, AL plus LPVR. Any more answers? AL plus LPVR, CPT is indicated. Oh, 1 minute. You've written, somebody has written AL plus LPVR plus R, but the child doesn't have TB. Tuberculosis is not there. So we will not give super boosting with R. R is added only in presence of tuberculosis. Cervical lymphadenopathy could be a part of the stage asymptomatic or PGL, persistent generalized lymphadenopathy may be a part of clinical stage 1 of HIV. If TB was there, then we would have written that the child has got what? Extrapulmonary TB, TB lymphadenitis. We have not said. We just said cervical lymphadenopathy. There's no TB in this. So the regimen would be the CPT. Yes, it's indicated. What would be the dose? Dose is 5 ml once a day. Syrup, CPT, cotrimoxazole, 5 ml once a day, and ART regimen is AL plus LPVR. It's not super boosting of ritonavir is not needed. What needs to be done before ART initiation? What needs to be done before ART initiation? This is just a revision of the preparedness counting. So first line, you need to do a baseline investigation, including CD4 counts and percentage. You need to screen for OIs and manage OIs, including if for a screening for TB, preparedness counseling, identification of a caregiver, probably a secondary caregiver also, CPT to be initiated. And the most important is this child has got severe malnutrition. It's very important to manage the severe malnutrition in this child, because ART itself will not help. ART plus nutritional supplementation plus vitamin supplementation, that is what will work for the child to gain weight and grow properly and growth and development to occur. Okay. Yes, head to toe. I'm very happy you have said. Yes, we need to rule out whether the cervical lymphadenopathy is associated with tuberculosis or not. Agreed. So what is the ART to be prescribed in this? Sorry. Any answers? What is the ART to be prescribed? I think I showed you the answer. What is the ART regimen? 2 years. We've already told you. So what is the dose? Can somebody just tell me what is the dose? What is your prescription? Yes, AL, LPVR, but what is the dosage for a weight of 8 kgs? What is the dosage of abacavir, lamivudine? Raised. Okay, yes. Shweta, just somebody's raised their voice. Just unmute there. ART.
Ma'am, we are not getting an indication here.
Okay, in the chat box they had raised. Okay. The dosage is, first choice is abacavir. Regimen we've already talked about, AL plus lopinavir, ritonavir. Dosage would be pediatric AL 60-30 milligrams, 1.5 tablets twice a day, and syrup lopinavir, ritonavir 1.5 ml BD. Now, if syrup lopinavir, ritonavir is not there, then what do we give? Then, if that is not available, we give lopinavir, ritonavir pellets. LPVR 40-10 milligrams pellets, These are 3 capsules given twice a day. So how many of you all know how to give pellets? 1 and 1.5. No, it is 1.5 twice a day. The dosage, please check the dosage. I'll go back to the dosage chart. For 8 kgs, it is 1.5 and 1.5.
Ma'am, you're going ahead.
I'm going, yeah, I know. By mistake, I went ahead instead of back. Okay, so the dosage chart is abacavir lamivudine for 6 to 9 is 1.5 morning, 1.5 evening. Please look at the new dosage charts which are given. Please don't follow what is given in the old dosage charts. These dosage charts are as per WHO guidelines 2021. So abacavir lamivudine 60-30 for 8 kgs would be 1.5 milligram, 1.5 tablet morning, 1.5 tablet evening. The dose of LPVR 40-10 pellets would be 3 capsules in the morning, 3 capsules in the evening. If the syrup is there, 80-20 milligram per ml syrup would be 1.5 ml in the morning, 1.5 ml in the evening. Okay. So just be careful about what is the dosage you have written. Okay. You must check every time. Don't learn it by heart. That is what I want to tell you, that every time you write the dose, check the doses, please look at the dosage chart. So now we'll talk about what are the formulations available. This is very important because a lot of medical officers and ART staff are not very confident about the pellets. So what are these pellets? These pellets are actually capsules with small, like something like homeopathic medicine given in capsules. But these are actually lopinavir, ritonavir, very stable. They can be kept in room temperature, though the temperature should not go beyond 30 degrees. So you don't need like syrup lopinavir, you need to put it in the fridge. Here you don't need to, it can be kept in the drawer also. But these capsules are not given fully. The child is not, capsules containing this must not be swallowed whole. So how do we give it? We need to open the capsule, collect the dosage of all. If it's 3 capsules, open 3 capsules and put it in a katori, and then not the whole thing at one go. We need to, so in children who are breastfeeding, we give it with milk. Those who are eating semi-solid, then in the layer of food, and it should be immediately be given along with after putting the medicine, because if the child keeps it for too long, it becomes sticky and it will get stuck into the soft palate. So it has to be swallowed immediately after giving it with food. Please see these videos. These videos are available in the, so there are these videos available in the NACO website. I will share the video link, but if you go to the NACO website, there are videos available about oral LPV pellets, both in Hindi and English. And you can actually show these videos to your parents, so that first the ART staff should be trained on how this is to be given, and thereafter these videos can be given to the parents to teach them how to give it. So in that, there is a video in which the child who's taking with breast milk, how you put the breast milk in a spoon and put the pellets, and how it is to be given in children who are eating semi-solid food. So syrup, though not available nowadays, but still I'm just talking about the syrup. The problem with this syrup is that it has to be kept in cold chain. It has to be stored in the fridge. Once it comes out of the fridge, it can be kept at 25 degrees centigrade for 42 days maximum. So you can only use it for 6 weeks. After 6 weeks, because it has been out of the fridge, and you have to maintain it at 25 degrees. So in places where it's very hot, we usually say that you keep it in a matka of pani, so that the bottle remains cold. And you have these pediatric tablets, which are 100 milligram of lopinavir, and ritonavir is 25 milligram. These are heat stable tablets. Remember, they are not supposed to be, they are supposed to be swallowed whole and must not be broken. So actually, the important thing is that you need to give oral pellets till the child is able to swallow, so that they can swallow. Though these tablets are huge tablets, it will be a little difficult, but once the child learns how to swallow, they'll be able to swallow these tablets. But a lot of mothers are actually breaking it and crushing it and giving it, but it's bioavailability or its efficacy reduces when you break these tablets or crush these tablets. Now, this is another case scenario. 7-year-old child, weight 24 kgs, clinically stable, no OIs, CD4 386, HP is 12.6. All other investigations are within normal, prepared for ART. Now tell me, the question is CPT indicated in this child, and what is the ART regimen with its dose? I'll wait for answers for a minute. ALD, okay. Anybody else? 2 have said ALD. CPT not indicated. Any more answers? Just half a minute more and then we can go ahead. Okay, CPT is not indicated. Okay, very happy that people are interacting and writing answers. So let's see what is the answer. So CPT is not indicated because the child is asymptomatic, clinical stage 1, CD4 is more than 350, and hence in children more than 5 years, it is CD4 and clinical stage which decides whether CPT is to be given or not. Okay, prescribe the ART regimen with those. It is ALD, as DTG can be given in children more than 6 years and 20 kgs. So this child is 7 years and 24 kgs. Yes, ALD can be given. But tell me the dosage. Look at the dosage chart and tell me how will you do a prescription of AL, because it's going to be abacavir, lamivudine, FDC plus DTG separately. So what is going to be the dose? Please tell me. I'm waiting for you all to tell me. Any answers about the dosage?
Participants are requested to please type in the chat box.
Do you have a pediatric dosage chart to have a look at what is the dosage? Should we go back to the dosage chart? Somebody has written an answer. AL3BD. What about DTG? What is the dosage of DTG? So somebody has written 3 and 3.5. 3 and 3.5. DTG OD. Okay. Let's go back to the dosage chart so that we are very clear how to look at a pediatric dosage chart and how to write a prescription. So quite a few have given right answers, but let's take this time to look at the dosage chart. Yes, who's raised the hand? Shweta, somebody has raised the hand. I don't know. Reshma has raised the hand. Okay, so we are talking about abacavir, lamivudine, 60-30, 24 kgs would be 3 morning, 3 evening. So that person who has written 3 morning and 3.5, please look at the latest chart. It is 3 tablets in the morning, 3 tablets in the evening. Okay, and DTG would be 50 milligram once a day. Okay, it's clear? Yeah, and 1.5, 60-30 is not 1.5 morning and night. It is 60-30 it's 24 kgs. It's 3 tablets in the morning and 3 tablets in the evening for a child who's 24 kgs weight. So ALD, the dosage is ABC, abacavir, lamivudine, 60-30, 3 tablets in the morning and 3 tablets in the evening, and DTG 50 milligrams, 1 tablet once a day. This is the answer. So now case scenario 4, Miss D. Yeah, but the 3 and 3.5 is as per the old chart. Now we've got new guidelines. Please look at the new guidelines. Follow the new chart, which is the WHO chart. WHO dosage chart. So we have new WHO guidelines come out in 2021. We have followed those 2021 WHO guidelines and we have updated our guidelines. So please don't follow the old charts. Please take printouts of the new charts which are there in the national guidelines for HIV care and treatment. If needed, Shweta, I think we should share that soft copy of that dosage chart if it is possible with all those who have attended this. I don't know how we'll be. Maybe in the chat box, if you can share it, or
we'll share it with the PPT and recorded link, ma'am.
Okay, please share the annexure. It's annexure 2, I think, if I'm not mistaken.
I will check it and I'll send it, ma'am.
Yes, because they are all following the old chart. Okay.
Right.
TLD is cannot be given. So somebody is written. In this, you're answering this question. So a child 13 years old, clinical stage 1, 38 kgs, 10 grams, hemoglobin, CD4 458. Is CPT indicated? People have said no. No CPT and TLD. Very good. So what is the dose of TLD? CPT not indicated because CD4 is more than 350, clinical stage is 1. ART, TLD, because 300 milligrams of tenofovir can be given in more than 10 years. This girl is 13 years and weight is more than 30 kgs, 38. So 1 tablet once a day at bedtime, or we can fix it according to the child's convenience. Okay, very good. Now this is one more case scenario 5. Mastery. 2 years, 9 months old, HIV infected boy who presented with altered sensorium since 2 days and cough and fever since 1 month. Father had TB. The child is now diagnosed with TB meningitis, has been started on ETT. 14 days have been completed. His body weight is 9 kgs. CD4 is 14%. Remember, less than 5 years, we look at the percentage. And HB is 9.8. So is CD4 indicated in this patient? First question. Yes. What is the dose? Any more answers? Yes, you've written, but I would like you to tell me the dose also. So look at the, yes. Any more answers? Percentage ml? Percentage, I think there's been a typo error. So yes, very good. Everybody has answered it correctly. So it is CPT is indicated because it's clinical stage 4 and child is less than 5 years. Both criteria are met. It is cotrimoxazole 5 ml once a day. What is the next question? When should the ART be started in this child with TB HIV co-infection? What are the new guidelines say? Anyone? When do you start ART? Do we start ART today? Now that the child has completed 2 weeks of anti-TB treatment, the child is stable. Can we start ART now? Let's hear some answers. ART to be started 2 to 6 weeks after ATT. What are the latest guidelines? The national guidelines 2021. Yes, after 2 weeks. Okay, so we've got different answers. So let's see what is the other answer given. Within 7 days, if tolerated, ART with ATT to be started together. I think we've got varied answers. Now let's look at what does the guidelines say. Guidelines, national guidelines for HIV care and treatment 2021 says that ART should be started after completing 4 weeks of anti-TB treatment. Remember that this child has got TB meningitis. So the ART initiation timing is different for those who have TB meningitis. Because they have higher chances of iris, we delay the ART initiation in children and adults who have TB meningitis. So usually started after completing, those who have TB meningitis, they have to be started 4 weeks after completing anti-TB treatment and before 8 weeks before the child's intensive phase gets over, the child should have been started on ART and corticosteroid should be added as a adjuvant therapy for TB meningitis. Let's just see what is the guidelines. So the guidelines, these are the national guidelines. It's present. The source is table 3.2.6 in chapter 3.2. Please have a look. You take a printout. Remember this. So CLHIV co-infected with TB. If it is anything besides TBM, initiate anti-TB treatment first and ART should be started as soon as possible within 2 weeks of TB treatment started, irrespective of CD4, except when there are signs of meningitis. So if there is signs of TB meningitis, so CLHIV with TB meningitis, ART should be delayed for at least 4 weeks and initiated within 8 weeks after starting TB treatment, and steroids, corticosteroid should be considered adjuvant. Why is this being written? Because you will see that this child who has TB meningitis is admitted in the pediatric ward, and the child is not being given corticosteroids because the child is HIV infected. Lots of clinicians have a hesitation of giving corticosteroids. So the indication of giving corticosteroids in TB meningitis is there. This child should benefit with corticosteroids as an adjuvant therapy to anti-TB treatment in TB meningitis. And we usually start ART after 4 weeks and should between 4 weeks to 8 weeks, that is of ATT treatment. So the child should have been started on ART before the intensive phase of ATT gets over. I hope this is clear. The new guidelines are clear. What is tablet 450 is correct or not? What is 450? I didn't understand. Can somebody just write and explain what is this tablet 450 they have written? Just write tablet 450 is correct or not. ART Center Salim, please explain. I don't know what is 450 tablet you're talking about. So these new guidelines should be adhered to. So next, 1 minute. I think we jumped a question. So the next question is that I've repeated it again. What is the ART regimen in this child? Because the clinical scenario finished. Now this child is completed 4 weeks of anti-TB treatment, and now we need to start ART. So what is the ART and what is the dose to be prescribed? I'm waiting for a minute for all of you to answer. Shweta, I know we've gone beyond 3, but just a few more slides.
No issues, no issues.
Ma'am, but CD4 is less. I didn't understand what they've written. AL plus super boosted LPVR. Okay, AL plus LPVR. Please tell me the dosage. Everyone, please tell me the dosage. I'm waiting for you to tell me what is the dosage. How are you going to prescribe it to the child? Regimen is right. You've written right, super boosted LPVR. But what is the dosage of AL and what is the dosage of LPVR and what is the dosage of ritonavir, additional ritonavir? I want to know that. Please look at the dosage chart and tell me. It's not there in the screenshot because the ritonavir is not there, but it is there in the annexure in the guidelines. So 1.5 AL BD. What is the weight of the child? 9 kgs. Okay, dose for AL is right. But what about lopinavir, ritonavir? And how much additional ritonavir is to be given? Just half a minute more. I'm waiting for more answers. Okay, AL 6030, 1.5 BD. I agree. LPVR. What about the additional ritonavir? Okay. So let's see the answer. So the regimen is AL plus super boosted lopinavir ritonavir. That is lopinavir ritonavir plus, because we are going to be giving it with rifampicin, we need to increase the dose of R. So LPVR is actually 1:4. We need to make it 1:1. So additional ritonavir is to be given to the child till the child is on ATT. So what is the thing? Abacavir, lamivudine, 1.5 tablets twice a day with syrup lopinavir 80-20, 1.5 ml twice a day. Or if lopinavir is not there, syrup is not with there, we talk about lopinavir, ritonavir pellets 40-10, 3 capsules twice a day, and a tablet ritonavir 100 milligrams, 1 tablet twice a day. Addition, we need to give this. Okay, why do we need to give additional ritonavir? Firstly, let's just look at what is the regimen. 15, it's 100 milligrams of ritonavir twice a day. Please go back and see. This is the answer. Ritonavir 100 milligram, 1 tablet twice a day for those children who are of the weight 9 kgs. You can look at the dosage chart, which is there in the guideline in the annexure of pediatric dosage chart. So let's just revise what are the first line ART regimens in children who are co-infected with TB. If the child weight is less than 20 kgs and age is less than 6 years, we give AL plus LPVR because we are getting a PI rifampicin will reduce the levels of lopinavir-ritonavir because of interaction. So we give additional ritonavir in a ratio to make it 1:1. So we are going to be giving it twice a day. And abacavir lamivudine as per weight band twice a day. If the child is weight between 20 to 30 kgs and age 6 to 10 years, the child will be given AL plus D plus additional dolutegravir 50 milligrams. Additional, because dolutegravir and rifampicin interact, rifampicin reduces the drug levels of dolutegravir. Because the child is on rifampicin based ATT, we need to add additional DTG 12 hours after the first dose. And that's why we say that we are going to be giving abacavir lamivudine twice daily as per weight band. And we are also going to be giving DTG 50 milligrams twice a day. Now, if the child's weight is above 30 kgs and age more than 30 years, we would be giving TLD plus D. Sorry, TLD plus D as we give it in adults. That is, we give additional dose of dolutegravir, additional dose of DTG 50 milligrams after 12 hours. Now, remember one thing, that this DTG dose will need to remain twice daily for 2 weeks after the last dose of rifampicin. We have to continue it for 2 weeks after stopping ATT, because the effect of rifampicin continues in the liver, the microsomal enzyme stimulation. So we need to continue this additional dose for 2 weeks after stopping rifampicin or ATT, and the super boosting of lopinavir with ritonavir. So the additional ritonavir will also continue 2 weeks after stopping ATT. Is this clear? Any question? Okay. Yes, agreed. So here it is, that why are we doing the super boosting? Just to explain, rifampicin is a strong enzyme inducer, accelerates metabolism of protease inhibitors. To maintain the level of protease inhibitors, we need to increase the ratio of LPBR from 4:1 to 1:1. And how do we increase this? This is increased by giving additional ritonavir along with lopinavir. So this is called super boosting of lopinavir, written as LPBR R plus R. And this is continued 2 weeks after stopping ATT. So this is again the pediatric dosage chart. The chart for additional ritonavir, if you look at the boosting for a child who is 9 kgs of weight, it is 1 tablet 100 milligrams morning and 1 tablet 100 milligrams in the evening. So what we are giving is abacavir lamivudine 1.5 60-30, 1.5 tablet morning, 1.5 tablet evening. We are giving lopinavir 80-20 milligrams, 1.5 ml morning, 1.5 ml evening. If we have pellets, if we are going to be giving pellets, then lopinavir, ritonavir 40-10 pellets, that is 3 capsules in the morning, 3 capsules in the evening, along with additional ritonavir for super boosting of 100 milligram, 1 tablet twice a day. Okay, I hope this is clear how you're going to be doing the super boosting thing. Now, these are certain practice problems. These are few practice problems. Shweta, do we have time for these practice problems?
Yes, ma'am.
Okay.
Yes, ma'am. You can
so
just
we give them 5 minutes. No, sorry, 2 minutes to just answer. First question.
Yes.
12-year-old, weight 32 kgs. 6 gram hemoglobin, 200 is the CD4, no OIs. What is your prescription? With dosage. What would be the ART and the dosage? Any answers? Okay, somebody's written in the chat. TLD, OD, okay, okay. Yes, that's the answer. TLD with CPT, very good. Don't forget the CPT. I want a full prescription, very good. I'm so happy that there are people who remember CPT. So in children, always remember about CPT. Adults also, but in children, it's more important because they are more susceptible for infections. So the first answer is TLD once a day. And what is the dose of CPT? Tablet co-trimoxazole DS, 1 tablet once a day. So remember, tablet co-trimoxazole beyond 30 kgs can be given, the adult dose can be given in weight beyond 30 kgs. Okay. Otherwise, what is given in the CPT is beyond 22 kgs. It is between 22 kgs to 30 kgs is 1.5 tablets of single strength. And beyond 30 kgs is double strength, 1 tablet once a day. That is the adult dose. So next problem, next 7 years old, 15 kgs, male child, 8 grams hemoglobin, 500 cells, no OI. Can I have some answers for this? ALD, any other answers? AL plus LPVR, any more answers? Okay, very good. You've given me the dose, but you've not given me the dose for LPVR. No CPT. AL, adult, half tablet OD? No, AL cannot be given half tablet OD after 15 kgs, for 15 kgs. ALD, okay, AL, LPVR, no CPT. You've not told me the dose of LPVR. Should I go back to the previous slide for you to tell me what is the dosage? Tell me now, what is the dosage of LPVR? So the regimen is LPVR, what was the weight? 15 kgs, right? 7 years, 15 kgs. So LPVR tablet, pediatric tablet, 125 is 2 tablets in the morning and 2 tablets in the evening. Okay. And abacavir lamivudine, 60-30 is 2.5 tablets in the morning and 2.5 tablets in the evening. We cannot give abacavir lamivudine tablets, half tablet. We are not going to be giving adult tablets. Okay. We are going to be giving abacavir lamivudine 60-30, 2.5, 2.5. Now, why is it AL plus LPVR? Can somebody explain to me? Why is it LPVR? AL plus LPVR? Because both criteria are not met. So you can only give DTG in more than 6 years and more than 20 kgs. So one criteria, age is fitting, but the second criteria of weight is not fitting. So this child, till the child goes to a weight of 20 kgs, will be given abacavir lamivudine and lopinavir ritonavir. Now there is one question which somebody has talked about CPT as stage 4, but I have not said where is it stage 4 here. Nobody has said stage 4 here. Instead, we've written no OIs, CD4 500, HB 8 grams. So there is no CPT indicated, but abacavir lamivudine, lopinavir ritonavir, dosage of AL 60-30 is 2.5 tablets twice a day, and lopinavir ritonavir is 2 pediatric tablets, 125, 2 tablets twice a day. Any questions around this? Yes, weight of DTG, it should be more than. Very good, very good. And because it's 15 kgs, we are giving lopinavir ritonavir. Okay, next answer to the next 9-year-old, weight 22 kgs, HB 9 grams, CD4 550, no OI. Any answers for this?
AL DTG.
AL DTG, very good. DTG. Yes, yes. But no, what is CPT. The dose? I want the dosage chart, dosage prescription.
AL is 3 BD.
Okay.
And DTG is 50 OD.
Yes, very good. So ALD is 60-30, 3 tablets twice a day, and DTG 50 milligram once a day. Very good.
And no CPT.
No CPT, because the child is more than 5 years, no OI, so you assume that the child is in clinical stage 1 and the CD4 is more than 350. So no CPT. Very good. This is how we write the prescription for a child. Now, sorry, tell me the next answer. Ma'am, 15 kgs in 7 years is severe malnutrition. Agreed. So you need to treat the malnutrition. You must find out why the child is malnourished. Is the child? Yes, agreed. But here we are not talking about management of malnutrition. We are talking about it's a practice problem where we are talking about what is the ART regimen. And the point to highlight was, yes, we need to manage the severe malnutrition. And we will continue with AL, LPVR if the weight is till the child becomes 20 kgs. Okay, tell me the answer to the last question. AL plus
lopinavir
with
with CPT.
Okay, so I agree with you. You're saying no CPT, the child is malnourished, so it's clinical stage 4. So CPT should be given in that child with 7 years for 15 kgs. Agreed, ma'am. Your CPT should be given because though the CD4 is 500, the clinical stage is severe malnutrition, which is stage 3 or 4, depending on where it comes in the moderate or severe, depending on the Z score, the growth chart. And it will come as less than -3 Z score. So this is actually CPT will need to be given in this child, the second problem. Very good. I'm very happy that you noticed that even though the CD4 is more, the clinical stage comes out to be 3/4, hence needs to be put on CPT. Okay, last answer.
AL lopinavir.
Yes, so
AL will
AL
be
is
1.5.
1.5 BD. What about lopinavir? What about lopinavir?
Lopinavir will be 1.5 ml BD.
Somebody's written 3. Actually, you're writing the capsules, the pellets. Yes, very good. I'm so happy that all of you have written. Now, will this CPT be given to this child? Next question, CPT? Yes or no? CPT for the 4th child, 3 years, 9 kgs? Yes. CPT has to be yes. And what is the dosage of CPT, please? Please tell me the dosage. I'm waiting for the chat box to give answers. Yes, CPT, yes, agreed. But I want you to learn how to write the dosage. 5 ml once a day. Yeah, so just don't write 5 ml. Please write 5 ml once a day. No, 5 ml once a day. Yes, that's the prescription. Very good. I'm very happy. Thank you, everyone, for the interactive session and answering the questions. So just the last slide, what is a recap of how you start steps in initiating ART in children is first we confirm the infection in children who are more than 18 months and who are less than 18 months. We perform baseline investigations. We do a baseline assessment head to toe, do CD4 counts, treat and stabilize the acute conditions, the opportunistic infections, initiate CPT, prepare child caregiver, have a secondary backup caregiver and the child for lifelong ART, and then initiate first line ART. Okay, thank you so much. Any question, Shweta?
Ma'am, we have a few in the chat box. We'll
Okay.
just finish up the post-test. You can give
And
up with
then-
the answers and then we'll take up the questions,
Okay,
right?
okay.
Pravinji, can we quickly run the post-test, please? Thank you, sir. Requesting all the participants to take up the post-test questions. You have already gone through the questions, so we'll have 2 to 3 minutes for this. There are 4 questions in all. Please scroll through all the 4 questions and answer them.
We've covered most of this in my session. So now you should all get 100% in this answers.
We'll end the poll now.
Okay.
Ma'am, we can go ahead with the answers.
Yeah. So let's look at the first question. So the age of the child is 12 years and 32 kgs. So we can give tenofovir in children more than 10 years and 30 kgs. So the regimen actually would be TLD. TLD, why? Because the age of the child is 12 years, more than 10 years and more than 30 kgs. So correct answer is TLD.
Ma'am, you'll have to change the slide.
Yeah, I'm going down. Now you can see the question. Is it visible,
No,
Shweta?
No, ma'am.
So how do I show the, because
just the next slides, ma'am.
okay. I thought maybe in the poll I should be.
Achha, no, ma'am.
So the pre-poll
Yes.
first question is 32 kg weight and 12 years. Now, because both criteria are met, more than 10 years and more than 30 kgs is TLD. So adult TLD can be given in CLHYV who are more than 10 years and 30 kgs. So the right answer is TLD. But still few people wrote ALD and ALLPVR, but this is very clear. You must look at the age, the weight, and then decide what is the regimen. The second question is that a child who's 7 years of age and 15 kgs, the regimen would be AL plus LPVR because the weight is still less than 20 kgs. So ART regimen CLHIV less than 6 years and 20 kg weight is AL plus LPVR. Remember, note that both criteria of age and weight are to be met. So we can't give DTG in this scenario till the child reaches a weight of 20 kgs. So anybody who's less than 6 years and 20 kgs, the regimen is AL plus LPVR. Third question, a child who's 9 years of age and 22 kgs. Now this child of 9 years and 22 kgs can be given ALD because we will give AL, we can't give tenofovir, but we can give DTG. So ART regimen in children between 20 to 30 kg and age between 6 to 10 years is abacavir, lamivudine, DTG. Both the criteria of age and weight need to be met. Okay. The fourth question is, a 3-year-old child with TB lymphadenitis with 9 kg. Now, because this child has got TB, HIV co-infection, we need to remember that we need to address that. So a 3-year-old child with weight 9 kgs, the regimen would be AL plus LPVR plus R ritonavir boosting additional because the child has got TB at lymphadenitis. Now, ART regimen CLHIV less than 6 years and 20 kgs is AL plus LPVR. And because it's HIV TB co-infection, we need to give additional ritonavir to cover the interaction with rifampicin. Thank you, everyone. Now, any more questions? There are some chat box questions. Thank you. Okay. Please.
Yeah, there's a question. Why do children not get night sweats?
Because night sweats is not a common symptom in children. The simple word is this. The common symptom which we have for TB, which points to TB, is cough, fever, history of contact. History of contact is a very important symptom which we need to think of the risk of when the child is in contact. The pediatric TB source is from adult TB. The source of getting HIV is from adult TB. So these are the symptoms. Children do not get night sweats. This symptom is not equal to TB, suspecting TB. That is why it is not that children don't get night sweats. It is that night sweats in children do not, or sweating in children does not indicate TB. How do you calculate CD4%? So CD4% is calculated usually if you have a CD4 machine, which are the latest CD4 machine. In that CD4 count, you will get CD4 machines. Otherwise, you will have to do what is called absolute lymphocyte count. So CD4%, the calculation is the CD4 count or the percentage of what is the CD4 counts ratio to the total lymphocyte count. That is what is CD4%. But you don't need to calculate because nowadays, whatever point of care machines also give you a percentage, CD4%. If a child is allergic to CPT, we can give dapsone, but then we have to be very careful and we need to get the child evaluated by a pediatrician before we advise dapsone, because the dose of dapsone needs to be this thing according to the weight of the child. Is ritonavir STC क्या होता है? What is STC?
Participants can now unmute their mic. Ma'am, I'll just check the question is from which ARTC. We can go ahead with the other question.
Okay, the last question. So in case of HIV, TB co-infection in adults, no, please, this is the old guideline. These are old guidelines. Please look at the new guidelines. The new guidelines are exactly what I showed you. That if the child or adults have TB, HIV co-infection, we start ATT followed by ART within 2 weeks of giving anti-TB treatment. If the child or the adult has TB meningitis, we need to postpone the TB. So this which you're talking about is not the latest guidelines. Okay.
Ma'am, SDC is single drug combination.
Yes, ritonavir 100 milligram tablets is available. If it's not available in your this thing, SAATHII is supposed to make it available. 100 milligram ritonavir single tablet is available.
Participants can now unmute their mic and ask questions, if any. Any questions from the participants? Please feel free to unmute your mic. You can also type in the chat box.
The adult
Hello?
guidelines. Hello.
Hello?
Yes, please tell
Actually,
me.
I just want to ask one question. We have a child admitted 3 days back. The child is HIV exposed. The mother is on ART, on irregular ART. And the child is 4 months old.
Okay.
And weight is just 2 kg.
Okay.
Child
But-
was admitted with oral thrush and bilateral pneumonia.
Okay.
Relatives brought the child.
Okay.
Now,
Have you?
Now it is a child is admitted in the pediatric department. They are looking after for pneumonia treatment and oral thrush.
Yes.
And
yes.
now I have to start a ART of the child.
Yes. Yes.
And what dose I should start
Yes,
of
you cannot.
AL
Yes, because they start with from a dose of 3 kg, right? That is what you're saying.
Yeah, that's
The
why
chart
I'm
is from
asking.
3 kg. So the child is not stable. Dr. Shabnam, the child is not stable at present. You cannot start ART
Yes,
in an
I
unstable.
have not yet started ART.
So
but
first thing is
pediatrician
then,
asking me.
yes. So first thing is send DBS for that child. We need to confirm HIV infection in that child. Rule out tuberculosis. Bilateral pneumonia.
DBS has been sent, but its report will come after 6 weeks or 2 months, I think. We are not getting our DBS reports since many months.
Okay, where are you? Which state are you from?
I am from Ludhiana, Punjab.
Okay, you have a center of excellence in PGI, Chandigarh.
Yeah, I was planning to send.
No, don't plan.
Reports,
Please send a.
I consulted telephonically to Dr. Ravinder, my in charge of COE. So she told me to refer the child to PGI ACP. But the relatives are not ready to go there. So I asked my pediatrician to rule out other OIs like CMV, fundus examination of the child and gastric aspirate, or to rule out tuberculosis. That is being done in a day. I think it will be done by tomorrow.
The child needs to be of weight 3 kgs before you can start the ART. But if the child needs to be started on ART, you need to consult the pediatric center of excellence to tell you what is the dosage which they can give.
Okay, so I will refer electronically mail. I will send.
Yes, do a SAATHII referral to the pediatric center of excellence or the center of excellence. You can also send it to Kalavati Saran Children's Hospital. Okay, Delhi, for an opinion that we have a symptomatic HIV exposed baby. The baby is 2 kgs of weight. Please tell us after stabilizing.
The other feeling is also actually the father died 4 months back.
Okay.
Then the mother sold the child to some other family. When it was detected positive, then it had to be positive, like antibodies are still there in the child of the mother. but they got it tested when the child was not gaining weight. So it was HIV positive, and they sent the child back to the relatives.
Okay, so in these scenarios where we need to calculate the dose as per the weight, and in the and the weight is that band is not given in the dosage chart, we need to refer these patients to the pediatric center of excellence. It has to be
moreover, we are
documented.
not having Prevnavir syrup. We are not having pellets cannot be given.
No,
to this
pellets
child.
cannot be given. Syrup has to be given. You have to tell your SACs to get the syrup, procure syrup for them.
So I can wait. I have started the Saffron. I can wait for the initiation of ART.
Agreed, but
for a
please
week.
take an opinion from the pediatric center of excellence.
I
They
think
may give you a
definitely-
dosage. So you need to tell
definitely,
SACs to procure
but-
syrup, lopinavir, ritonavir for that child.
Yeah.
Okay.
I just asked the question because of this session to you. Otherwise, I had to refer
Yes.
to the ACP department. Okay, thank you, ma'am.
Welcome, welcome. Any more questions?
Welcome.
There was one question in the chat box, Shweta. Which one? What is the single drug? Yes.
Yeah, we
So-
have taken all of the questions from there.
Huh.
Any more questions from the participants?
Good evening, ma'am. I'm Dr. J. Suraj.
Good evening,
Ex-
sir.
Please repeat. I couldn't understand what you're saying.
Good evening, madam. I'm Dr. J. Suraj. I'm
Yes.
calling from Tamil Nadu. Regarding iris, madam, how to
Yes.
differentiate iris in adult and pediatric and due then to other causes like autoimmune and malignancy.
Okay, so iris means that there has been immune response. So the CD4 count oblique the CD4% if the child is less than 5%, 5 years, we need to show a rise in CD4% or CD4 count in presence of an opportunistic infection. So if the child has an opportunistic infection, you need to differentiate, is this OI or is this iris? The way to differentiate is to do the CD4 counts and the CD4%. And how much has it risen from the baseline? If the CD4% is high as compared to the baseline, or the CD4 count is high, then it is iris. If it is plain opportunistic infection, the CD4 only falls or remains static. Iris always happens when the immune responses occur. That is, the CD4 counts have increased in number. Only then iris occurs. Okay.
Thank you so much, ma'am, for this interactive and informative session.
Any more questions,
Thank you.
Shweta?
No more questions, ma'am.
Okay.
Requesting participants to please email their questions to us and we'll forward them to ma'am.
Okay. Yeah, please.
Thank you so much, ma'am.
Welcome.
And thank you to all the participants for patient listening. Sorry, we short of the time. Ma'am, can we conclude the session now?
Yes, thank you everyone for being interactive and helping me go through this session, though it took half an hour extra. Thank you, everybody. Thank you, Shweta. Thank you, iTech support.
Thank you, ma'am.
Thank you.
With the PPT and the recorded link, we'll be sharing the pediatric dosage chart as well.